يلا. Ready to go. Go.
Okay. Bismillah ar-Rahman ar-Rahim. In the name of Allah, the most gracious, the most merciful, and prayer and peace of Allah be upon Prophet Muhammad. Good evening, everybody. My name is Dr. Uthman Ayoub, consultant hematologist from Al-Hada Armed Forces Hospital. On behalf of the organizing committee and the Saudi Society of Blood Disorder, I'd like to welcome all speakers, moderators, and participants to the 5th day of the annual Saudi Hematology Congress. The society has been working for more than 2 years since it has been established and has participated in many activities for professionals as well as patient educational activity. And recently there was some activity with the Saudi Commission in establishing practice guidelines and clinical pathway. And the topic which was participated by the society was about the anemia clinical pathway. I'd like to express our great thanks and appreciation to the organizing committee for the excellent program, excellent topics, and excellent speakers. We have really enjoyed the previous days, and we hope that we'll enjoy the remaining days of the Congress. And also great appreciation to the technical support team for their great job in following all the technical issues during the Congress. Today, we are going to have 2 sessions, and we'll continue talking about innovation in hematology. And there will be 3 talks about artificial intelligence in hematology practice. The number of audience for this Congress has been great, and yesterday we were approximately close to 4,000 participants. And today, as of now, there are 2,800 participants already online with us. And I'll leave the microphone now for my colleague, Dr. Marwan Shaheen, consultant hematologist from King Faisal Specialist Hospital. Thank you.
Thank you, Dr. Uthman. Bismillah ar-Rahman ar-Rahim. On behalf of the organizer committee, I want again to thank all the participants and the organizers and all of the support, as mentioned by Dr. Uthman. Your all effort, speakers, moderators made this meeting successful. Today, we have 2 moderators will chair the session. The first session will be chaired by my colleague and friend, Dr. Muhammad Al-Makadi, who is graduated from McMaster University in Canada and currently is an adult hematology consultant in King Faisal Specialist Hospital and Research Center Al-Madina Al-Munawwara. Dr. Muhammad will chair the first session. Then Dr. Al-Fadl Al-Shaybani, who is an adult hematology consultant in King Faisal Specialist Hospital and Research Center Riyadh, and who finished his training in New York, will and with a special interest in lymphoma, will chair the second session. I want just to remind everyone to write their questions in the available chat, and the moderators will take care of all the questions. And please, when you have time, go and visit the virtual exhibition tour, which is very a nice experience with a lot of nice videos in each company booth. I enjoyed it last time, and I will also visit it today. For the time being, I want to leave the mic to Dr. Muhammad Al-Makadi. Please go ahead.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Ayoub and Dr. Shaheen, and the organizing committee for the opportunity to be here this evening. We would like to thank our audience for joining us on our 5th day. That happens to be the 2nd day to discuss promising innovations in the field of hematology. Without further ado, allow me to introduce our first speaker this evening. Dr. Faras Al-Freih is a consultant hematology and stem cell transplantation and cellular therapy at King Faisal Specialist Hospital and Research Center in Riyadh. He is also the director of Unrelated Donor Registry program. Dr. Freih is also the president of the Saudi Society for Blood Disorders. Dr. Freih will start today's session. He will talk about the artificial intelligence, and if there is any. Hello, can you hear me?
Yes, we can hear you.
Yes,
we can hear you. Go ahead.
He will talk about the clinical applications of artificial intelligence and machine learning in the field of hematology, and also to cover if there is any newer opportunities and challenges in the field of artificial intelligence in hematology. Dr. Freih, thank you very much for joining us. The mic is yours.
Thank you, Dr. Makadi, and thank you for Dr. Uthman and Marwan. Okay. So I'll try today and just give an overview about artificial intelligence and machine learning in hematology. This is very important new field in healthcare, and with increasing adaptation, several subspecialties, including hematology. So this is my disclosure. The outline of my talk is I will start by giving an overview about artificial intelligence and machine learning. We'll switch to some clinical applications and opportunities, and then we'll try to address some challenges. I would also like to remind you that there will be two following talks, one about AI in diagnostic hematology and the second in AI in bone marrow transplant by Professor Salama as well as Professor Hashimi. So one of the challenging issues in the healthcare system globally is the increase of global health expenditure per capita. In 2017, the global cost was 7.7 trillion, and it's projected to be more than 25 trillion every year by 2040. Such expenses is a huge pressure on healthcare budget as well as system globally. That's why innovations to tackle this challenge is highly warranted. So one theory that has been studied in the literature as well as in the clinical practice is whether AI can help reducing the global GDP in healthcare system. So this is one study, and it looked at that artificial intelligence potentially can reduce the global GDP by 15 trillion by 2030, and primarily by improving or enhancing the labor productivity and utilization. Sorry. So AI is a branch of computer science where algorithms are designed to perform automated tasks. I would like to emphasize that AI is different than automation. It is a very common misconception. It's not just automation, it is an automation with algorithms that lead to a specific supervised output or unsupervised output. So AI has been a potential catalyst for value-based care. The value-based care is an important concept introduced in 2006 by Michael Porter and has been adopted by several countries globally. Value-based care is optimizing values, which are the outcomes that matter to the patient, not to the healthcare providers, through better process of care, patient experience, and reduced costs. So in any innovation, the biggest question or the frequently asked question is this a hype? when it comes to the AI and machine learning, it doesn't seem to be a hype. Several studies, not in healthcare actually, looked at the impact of AI in several industries, and healthcare was one of the top industries that expected that to be impacted by artificial intelligence and machine learning. In this report, AI as well as automobile industries are on the top of the list. So we have an artificial intelligence. The second terminology is machine learning. Machine learning is the use of algorithm to discover a relation between variables from a large data set and produce outputs. So there are several machine learning algorithms. Some of the commonest are logistic regression, as well as decision tree. However, the most frequently used are support vector machine and K-means because of its value in looking at a large database. Another important field, which is deep learning. Deep learning is very important subtype of artificial intelligence as well as machine learning. If we look at the difference between machine learning and deep learning, so deep learning is more sophisticated. There will be a network, a neural network, which is this one, which consists from at least 3 layers, while in machine learning, the layers are usually 3 or less. In deep learning, the extraction and classifications are both combined, and both machine learning and deep learning help in reaching the predictions. This is just an example of artificial neural network, which is used in machine learning, where you have the input layer, for example, age, gender, diagnosis. You have a hidden layer, and the third layer, which is the output, for example, transplant-related mortality. So I will switch to some clinical applications and opportunities. So in 2016, FDA approved the first deep learning clinical platform to help in diagnosing lesions in the lung and liver by CT and MRI. Subsequently, also FDA approved a machine learning algorithm to predict or actually to diagnose diabetic retinopathy in an automated way. There are also an algorithm that has been FDA approved to help in diagnosing wrist fractures with imagings. Radiology field has been one of the biggest field that with a lot of algorithms for machine learning. I believe probably one of the reasons is the volume of the data. If you look into the healthcare or electronic healthcare records, images per se account for majority of the data. The aim of AI in machine learning and radiology is to reduce human error, expedite diagnosis, reports. There is a claim it can accurately track the growth of the lesions, maybe better quantity and quality, which depends on the algorithm, and still this is a learning curve. And at the end, that even if you have a diagnosis by machine learning, that you can have it reviewed by a radiologist as a second opinion. This is an example, which is the lung nodules, the detection and the characterization. using a machine learning algorithms. Ophthalmology as well as cardiology is also another adapters of AI and machine learning. So there are more than 160 AI-based devices has been either cleared or approved by FDA as of now. Another important domains that AI can help is in the healthcare system is by reducing the waste when it comes to administrative, pricing failure, accounting and the finance, and also overutilization of resources. So if we look into the overall domains where machine learning can help is either drug development, decision support, warning systems or wearable devices, prognostications, diagnosis, pathogenesis, treatment surveillance. I will not go into details in hematology. I know Prof. Salama as well as Dr. Sharouk will go into the details. However, these are some examples of diagnostic value of machine learning algorithms. And there are actually a lot of publications. Machine learning algorithms can help in hematopathology, whether it's a morphology, aspirate pathology. It can help also in the imaging when it comes to diagnosing. For example, there's a study looking at diagnosing pulmonary fungal infection using machine learning. It might lead to reclassification of diseases with incorporation of gene expression. It might have a clinical diagnostic impact when it comes for GVHD, for example. These are some selected studies when it comes to diagnostic and classifications. Prognostication, there are several studies that looked at whether it can help in predicting GVHD, acute GVHD, for example, predicting outcomes of treatment, risk of relapse, risk of infection. This is one study looked at risk of developing infection in CLL, and again predicting complete remission with incorporation of gene expression in AML, and identifying risk of relapse in ALL. Therapeutic areas is very important. It can help in, for example, this is a study looked at, and probably Dr. Sharouk will address it more, is that the use of machine learning algorithm to select stem cell donor. Also, it can help in developing new medications by assessing its efficacy. For example, anti-leukemic compound, which the paper was published in July 2020. And it might overall help in selecting the treatment choices and providing the patient the best needed treatment with the better outcomes. So I'll switch to the last part of my talk, which are the challenges. So one important aspect is ethics. So health artificial intelligence ethics is highly warranted. Unfortunately, the available literature addressing this is limited. There are a lot of questions when it comes to how to share information. The biggest players when it comes to the machine learning algorithm are the tech companies, whether it's an Amazon or Google, and there has been a lot of lawsuits in US against some companies regarding the use of information with no previous approvals. Another challenge is actually that the AI, machine learning, as well as the ethics related to this field has to be included in medical education, which is lacking as of now. Quality and regulatory challenges. So it is very important that the machine learning algorithm lead to a needed outcome. So we cannot just take whatever comes as an output from the machine as a granted. We should look at it by skeptical eye, evaluate and re-evaluate. It needs validation, internal and external. It's important, actually. Probably many of you are aware with good manufacturing product. FDA has introduced good machine learning practices, GMLP. And the aim actually is to ensure that a software as a medical devices has a very high quality to get approved. It has to have clinical association, analytic validation, as well as clinical validation to be qualified as GMLP. FDA published several frameworks into how to lead the field when it comes to the AI and machine learning and regulate it. Patient privacy is one of the challenges, and already addressed that. And important thing is that if you review literature, there are many. I would say there is a huge number of papers on assessing AI and machine learning. This is very nice paper. Clinician's Guide to Artificial Intelligence: How to Critically Appraise a Machine Learning Study. And at the end, I would like to say that AI will allow doctors to be more human. It's unlikely that AI and machine learning will be replacing healthcare providers. So in conclusion, application of AI and machine learning models in healthcare is growing. More ongoing research with new algorithms in hematology specifically are warranted. Evaluating and implementing the algorithm with critical eye is necessary, keeping in mind the limitations of the algorithms. More attention to ethical challenges is also needed. And by this, I conclude my talk. Thank you.
Thank you, Dr. Al-Freih, for such a delicate talk on a field that is rapidly growing. We have actually a few minutes before our second speaker will start. If you may allow me, we can have some questions. I would start by saying you ended your talk by saying that people don't think that artificial intelligence will minimize human jobs. We believe this is true because when you're dealing with patients, it's a different story. It's not just numbers and formulas. So can actually artificial intelligence appreciate the heterogeneity between patients when we input certain information and the artificial intelligence will comes into delivering conclusions or suggestions? Will it actually appreciate heterogeneity among patients?
Thank you, Dr. Muhammad. It's an excellent question. It depends on the algorithm. And one of the biggest challenges in the algorithms is that when we are looking at the minority variables. So if the majority will be underrepresented, and that's why the algorithm probably will be better fitted for the majority than the minority. So in general, yes, it will be able to differentiate the heterogeneity. However, still we have to look into it in more details. Is it majority or minority? And so it is very, very difficult question and difficult to answer it.
I see. My second question would be, we always were hoping with artificial intelligence coming outside of the medical field, it will minimize errors. It's the same hope in the medical field. but would that actually lead to over-diagnosis or over-interpretation?
So one of the main corners of, a lot of attention and hype toward machine learning and AI is to reduce the waste. So the initial intent is actually to reduce the weight, reduce the over-investigation or over-treatment. However, you are right. I mean, there might be some abnormalities that will get over-diagnosed while others will be under-diagnosed. Yeah, I agree with you.
And from your experience and knowledge into this field, how soon you think we will see more role of machine learning and artificial intelligence in our region?
So in King Faisal, there has been some initiatives in adopting or actually developing some machine learning algorithms in diagnostic hematology. I think diagnostic hematology probably is one of the subspecialty in hematology where we expect a very soon adaptation of it. I'm sure Dr. Salama will address that in more details, but these are my thoughts.
Do you think our patient population will be ready? You actually talked about important aspects about readiness of the patient and ethics. Do you think our culture and population will be ready for such innovation?
And it's hard to tell, I have to say. I might say patients might not be ready. However, when you look at the adoption of technology and innovation in Saudi Arabia, I mean, for example, the technology by itself, whether it's a phone or social media, actually Saudi Arabia population is one of the highest countries when it comes to adoption of technology. Specifically for AI, definitely there will be some concern, reservation, but I'm optimistic.
Thank you so much, Dr. Fareeh, for your presentation. We're actually doing well with regards to time. So I would say we can move on to our second speaker if he is ready for this evening, Dr. Muhammad Salama. He is a professor at the Department of Laboratory Medicine and Pathology at the Mayo Clinic Hospital in Rochester, Minnesota. And he is the Chief Medical Officer of Mayo Clinic Laboratories. His clinical interest in hematopathology include morphology, flow cytometry, molecular tests, and other specialized studies of bone marrow and lymph nodes pathology. He will be talking about transforming diagnostic malignant hematology through artificial intelligence. I would like to thank him for joining us this evening. Dr. Salama, the mic is yours.
Thank you, Dr. Muhammad, I would like to thank the attendants and for their time, and I would like to thank the organizing committee for the invitation. It's a pleasure and honor to be with you today with this exciting topics session. So this is going to be the outline of what we will do in the next 25 minutes. We will start with some relevant historic perspective. We'll talk about the promise of the digital pathology and AI. We also will stress the fact that AI is beyond digital pathology, and we will touch on this. I mean, there's going to be areas in flow cytometry and some of the other tools that we use every day. We will talk about the limitation in the field, and then we'll try to address this in a way that we view, or at least on our end here, we view how AI is going to come in the lab and the diagnostics, particularly with relation to testing some pre-analytical elements, analytical elements of the testing, and the post-analytical elements. I would like to start with a little bit of a background addressing the evolution trends in the clinical lab that we see today. So we all are dealing with increased biological information, increasing and technological innovation, and actually increasing clinical demands. All of this results into any qualitative is becoming quantitative. All of our assays now are becoming quantitative. It's not good enough now to say there is a FLT3 or not. You want to know how much FLT3 is going to be, or if there is a mutation, what's the mutation burden. There is increased reliability on our testing with increased analytical precision. of our testing. Also, there is these results are tied directly now into treatment. They are not just for diagnosing entity anymore. I think there is a, looks like there is an error.
You can keep talking, Dr. Salama, until they fix your
Okay.
presentation.
Sure. Yeah, I am actually connecting through my, I'm sharing the presentation from here. So the promise of digital pathology and AI, this is going to be directly connected to the into the microscope. We are not going to rid of the microscope. We are not going to rid of what we do in the lab. It's actually going to be more valuable and more efficient. So as you noticed from the what I had there, I mean, I had somebody looking at the microscope and there are pictures in front of him. So what we anticipate in the future, that every image-based pathologist is going to be using computer-assisted analytical tools in the future.
هو في ثانك يو في برزنتيشن متشيره بس مش عارف دي بتاعته ولا بتاعت مين.
Yeah, I shared my أنا shared the presentation بتاعتي earlier, but I'm sharing from my computer as well.
Share it to your computer, please. Okay, share it again, please.
So AI, digital pathology enables AI, and we'll talk about this in a second. But AI, again, I'm stressing it actually extends beyond imaging. That we anticipate also there's going to be increased reliance on pathology as we have more AI and more widespread use of digital pathology. So a little bit of a historic perspective from the early 20th century until today, there have been only 3 revolutions. The first revolution was in the field of pathology. First revolution was 1980 with the immunohistochemistry, and then early 2000 was next generation sequencing and molecular. And now in 2008, we're starting to see a third revolution of digital pathology, and it really is a tool that enables really artificial intelligence. The digital pathology is not new. It existed since 1968, and artificial intelligence is not new. We talked about artificial intelligence in 1956. But what happened in 1968, the first image was transferred, digital image transferred between Logan Airport and Mass General Hospital. But it took a while for it because of the efficiency of the computer performance. And it wasn't until the late 90s where the internet came in place, and we started again to talk about digital pathology. The same thing for artificial intelligence. Artificial intelligence have existed a long time back, but why now is surfacing? Because the data are digital. We have access to a lot of data. In the 60s and 70s, all of our works in the hospital was paper form. There was really not much digitized form. So we have now the material, and this is where the opportunity exists for us. One thing I want to point out, when I refer to artificial intelligence, we always say AI for artificial intelligence. I actually like to refer this for augmented intelligence, and it's also referred to as AI. The reason why this is important, because artificial intelligence, augmented intelligence, or AI, does not mean it's going to replace us. It's actually going to make us better. It's going to make us more efficient. It's going to make us actually more capable. And we will talk about some of this. So why do we want to switch digital? Our predecessors in radiology have confirmed actually that image quality, access, consistency, and workflow can be greatly improved with digital workflow. In the lab today, We know counting cells or counting bone marrows, this is a very labor-intensive process. This is not standardized, difficult to train people, and no historic images. If one of my trainees bring me a slide and say, this have a blast here, Dr. Salama, can you look at it? Now I have to look through the whole slide to find the cell, and I may or may not find it because it may not have existed to begin with, or I'm not convinced that it's a blast. There's also improved traceability of these cells. Just to give you a very brief comparison, what really the difference about looking at a slide on a microscope and a slide. This is a peripheral smear. If you look at certain area, you zoom in microscope, and you can see I can tell this is a neutrophil because of the segmented nuclei. But if you go into the insets there, you see an inset A, there is a small granule, and this granule is made by 16 pixels. And depending on the mathematical way of the quality of this image and the way these are done, do you take averages? Am I going to be able to use this or not on the image? Because in the microscope, I actually zoom up and down. I can go higher magnification. And if I don't see it, then I may call this patient had myelodysplasia, hypogranular peripheral smear. And then you may need to do a bone marrow biopsy and so on. So there is quite a bit of limitation. Most of us are familiar with the format of files. So any given whole slide image is made of almost 50,000 different small tiles that they put in a wrapping like this pyramid. And you zoom in the pyramid depending on the top of the pyramid or the bottom of the pyramid, where you see how much details on the cells. But one of the major limitations I want to point out here, why heme path didn't go as fast as other area in surgical pathology, because it takes a long time. We did this study several years back, and to scan a 2x2 millimeter area on a slide, you need 8 minutes. You need 16 minutes to scan 9x9 millimeter area on 100x oil, which is impossible. If you have a lab that makes hundreds of slides every day, it's impossible to scan everything. Now, this is improved. There is a lot of new scanners in the market. I mean, the couple of the scanners that I'm showing here actually have promised. There was one Chinese manufacturer that have promised that they will have a whole slide scan under 30 seconds by the end of the year. And I think they are getting close there. I would like to think of this as a pathologist-centric system where AI, you can scan the whole slide. The whole slide is given to the pathologist. The pathologist is going to be looking at slides to make the diagnosis and then reporting. So artificial intelligence and AI can be at the beginning, I mean, pre-analytical, before the pathologist. And we'll talk about these in a second, and could be actually even later after the diagnosis, in addition to the function in the diagnosis. And obviously, the quality control goes all the way across during all the time, can be running in the background all the time. So this is a way that I preview the AI in clinical laboratory. We'll talk about some examples in the pre-analytical, case assignment, screening slides, pre-order of stains. We'll show you a few examples. The analytical, basically how you classify cells, how you make the diagnosis, how you assist in making a differential diagnosis. And then the post-analytical as directed, basically do repeated functions and maybe even natural language processing, where you can generate the report that's specific for a patient based on a specific function. So when the pathologists come or the technologist, they come, they can do things in 5 minutes instead of 25 minutes. And obviously, we'll talk also about flow cytometry, because there is a lot of work have been done in flow cytometry that I would like to share with you. We'll start with the pre-analytical. And before we do that, I want to give you a very high-level, basic understanding of what's really the difference between machine learning and deep learning. Machine learning is what we have done. We have been doing for the last 10, 15 years with image analysis. Basically, you train the machine, the computer, to learn to do certain function, the same way we learn in our life. And basically, you essentially, if this is a Hodgkin, as the example I showed there, you have to go and mark the cell and tell the computer, this is a Hodgkin or cell, and go and find all the Hodgkin cells for me. Deep learning is different because you really do not have to train the computer. The computer can go and find, you basically give 2 sets of data, and the computer can go and find its own features that different than what I look in my eye or my brain can recognize. And usually we do this through convolutional network. So we have taken advantage of this by applying this to some lymphoma. And I will take you through the study to explain more. And essentially what you do, each one of those layers that I had there, the convolutional neural network, is composed of images, portion of the image, which we call kernels. Kernels is a group of pixels. and each layer is dependent on the layer before it and learn certain features from it depending on the pixels, the colors, the texture, and they make mathematical combination of things, and they teach the next layer. And then when you write these, the engineers, when they write these layers, they at the end they group the cells based on these findings in one of those at the last layer in a group A or B or C, and this is how you get your answer. So we did the same thing a few years back, and we wanted to answer the question a couple of years ago, and we wanted to answer the question, can the computer read the Burkitt lymphoma from diffuse large B-cell lymphoma and say, this is a Burkitt or a diffuse large B-cell lymphoma? And we used the exact same principles that I showed you. We don't have to go into the details, but essentially we created into the concept, and essentially the system went very well into giving us the probability of making the distinction. What was in our mind at that time was very simple, that we wanted to use this in a pre-analytical. So the sample would come. It may take me 3 days, because day one I look at the diffuse large B-cell lymphoma or Burkitt lymphoma. I do 3 and 20. I can tell it's B or a T cell process. It goes next day to the immunostains. The second round come. I can tell it's a B cell lymphoma, and then I order the cell of origin, and maybe the third day I can get, is it BCL2 or BCL6. However, if I have a fellow, that AI fellow that's looking at a microscope here, that works, the slides actually, people in the lab, they come at 3 a.m. or 4 a.m. They do the histology. I come later in the lab, the fellow already have looked at it, the AI, they can tell with a very high level of accuracy, almost 99%, this is a diffuse large B-cell lymphoma, this is not a Burkitt lymphoma. The stain round, it can detect the top group, because there is a very high likelihood of accuracy. Will start the stains. By the time I come at 10 o'clock, I have the stains. I can sign the case on time by 10 o'clock or 11 o'clock, because I have the stains. The report is already written for me. It changes the practice. And now, instead of 3 days for get a diagnosis, you get 4 or 5 hours to get the diagnosis. And obviously the efficiency, I'm not going to talk about efficiency and the money and all of that, because now you are ordering stains that you know what it is. And there's also other questions that we are starting to ask now. Can I predict from the H&E only a double expressors or not? Do I have, can I identify the 70% of diffuse large B-cell lymphoma that's going to respond to the R-CHOP, or the 30% that's not going to respond, and automatically I'm going to have them to DICE or RICE or any of the other algorithms? There is a lot of publication in this area, and we don't have to talk about the details of follicular lymphoma and others, but you get the concept. The other area that I would like to point out too is like APL, the diagnosis of APL. We know that if the patient is not diagnosed within 48 hours, the mortality goes more than 50%, or even 24 hours, the mortality goes significant. So the question becomes, can we predict if it's APL or not with translocation 1517 with higher level of accuracy upfront, even before the flow cytometry comes? I'm going to move now to the analytical, and I will go relatively quick here. Why do we want to automate the manual differential for the cells? Because of availability of medical technologists, greater level of standardization, likelihood, and demand of connectivity between the healthcare provider, particularly you as a provider. So you can see what happened in real life. I would be looking at a microscope, we'll be seeing a field like this on the left side. I'd be counting the cells, but you would have a system like CellaVision or any of the other similar systems can organize the cells for you. This will make my life much better. I would be extremely happy. I believe any hematopathologist in the call will be as well. There are many systems exist. CellaVision, they come in a separate system or in a modular form with Sysmex or others, but the difference really between these different systems exist in the way the number of cells they provide, number of classes, and all of that. These systems, they can allow you to visualize the cell in high resolution. They allow you to look at the red blood cells with the assisted tools, with counts. You can organize the cells based on their shape, size, maybe annotated spherocytes pointed out, and so on and so forth. So basically increase performance. All of these systems, they use a knowledge-based artificial neural network algorithms that employ hierarchical structure classification rule that mirrors our manual teaching process, essentially what we use to train our trainees and fellows. And this is how it started. Maybe about 8 or 9 years ago, we started some of the machine learning concept where we're able to, in our lab actually, where we train, we use the simple triangulation method for the computer to identify a cell as neutrophils or not. But again, this have taken significantly faster into deep neural network now, where we see the accuracy have improved significantly. And again, the same concept that I showed you before, but it's cell-based and not a tissue-based. And you see the accuracy have improved significantly. We actually now doing some work where from the H&E only, we can look at 800 features per cell, and we can look at clustering. So we actually can tell clonality from just H&E or right stain based on the cells they cluster together, cells look like together. So there is a lot of advances. This is going to take quickly, very fast. I anticipate within the next 12 months, a lot of prediction in morphology is going to take over. However, we have to address the limitation. One of the limitations addressed is the scanning systems, but another limitation is actually all the data that we look in the literature are very significant when you are comparing two modes, normal or abnormal, blast or not blast, neutrophils or platelet, neutrophils or lymphocytes. But once you start getting into a higher level of challenges, basically when you challenge the system started to go down. So this is a Spanish group that they have looked at lymphocytes. If you look at APL, Burkitt lymphoma, CLL, margin zone lymphoma, or mantle cell lymphoma in the peripheral blood. So they looked at all the lymphoid and different diseases, and you can see the sensitivity dropped significantly. They used about 46,000 digitized cells. So obviously, we cannot tell exactly what they use in their neural network. But the point here, as we challenge the system with more possibilities, the efficiency is going to go down. So there's a lot of work to be done as well. Why this is important? The International Society for Standardization of Hematology, they recommended actually that all the labs give numeric values. And if you look at the everywhere in the world, so if you look on the right side, for you to call anisocytosis, I have to count how many anisocytosis or polychromasia or acanthocytes or echinocytes or schistocytes, and I have to tell you if it's 2+ or 3+ based on the count, and they vary from one to the other, and it's impossible for anybody to do this manually. So these systems are going to be essential for our progression. Why this is important? Because connectivity, and what this means to you, this actually slides from my friend Dr. Pintanovitz. They did at the University of Pittsburgh, where they actually looked about 3.4 million images, and they took it from the CellaVision, they put it on their server, and actually they made connectivity through the CBC to the clinician through the EMR. So you as a clinician, when you open the chart, you click on it, you actually can see the cells and you can review it as well in your clinic or from your cell phone. Assisting differential diagnosis, this is a study I would refer to that was done by the same group. They looked at feature extraction for cell segmentation based on the region, the cytoplasm regions, and the surrounding cells. And they look at geometric features, color, cytoplasm for 5 different diseases, and the normal lymphocytes, and like hairy cells, CLL, mantle cells, and blast, acute lymphoblastic leukemia. And you can see here on the left side, this is the true value, the gold standard or the ground truth on the left side. On the top, what's the system predicted just from the looking at the image of the cells. And you can see the performance. They can tell you with 99.5% accuracy this lymphocytes is normal or abnormal, or they can tell you with 97 or 98% accuracy this is CLL or mantle cell lymphoma. Obviously, this is gonna needs to be confirmed. But this is another study that actually I would like to, from a Japanese group, just came recently, where they looked at more than 700, almost 700,000 cell image from over 3,000 peripheral blood smears, and they classified the cells into 17 groups with 97 morphologic features. On the right side, you'll see what's called TISNE, or the distributed schematic neighborhood embedding. And this is basically a multi-dimensional reduction. So you can take thousands of dimensions and you put them in 2 dimensions. And they were able to separate these cells with a very high level of accuracy. Now, what they did next, they actually looked at the peripheral smears from MDS and aplastic anemia. We know this is a difficult diagnosis for patients with cytopenia. And they actually, you can see they were able to separate them with a very high level of accuracy, particularly for the top 3 entities, which I think was pseudopilgrahue, the nuclear shape, and the cytoplasmic granularity. What's impressive here is that they were able to identify, to make this distinction with more than 99, an area under the curve of 0.99 with a very high sensitivity, very high specificity, and 100% sensitivity. That we all know that this is a difficult diagnosis. But if I can tell you as a clinician that this upfront from a peripheral smear, this patient had a very high likelihood to be an MDS or aplastic anemia, then you may choose your testing, or I may choose my testing even before or even decide if I want to do a bone marrow or follow the patient later on, or even start the patient or a given therapy, a different therapy. This is not only one group. There are other groups are starting to show the same thing now. This is the same Spanish group that I told you about. They are able to tell from just the peripheral blood if the cells have a dysplasia or not with a very high level of accuracy, with an area under the curve of 0.99, almost 100%. This goes beyond the morphology. So this is another group from San Diego, University of California, San Diego, where they looked at when you get a peripheral smear and I tell you there is a blast there, they actually applied an AI on sets of questions on the electronic medical records. And they asked sets of questions for those patients within 30 days of the identification of a blast. Simple questions like, did the patient had received stem cell mobilization or not? Did have corticosteroids? The patient had infection? Was there is other abnormalities or not? LDH and so on. And the answer for those that are neoplastic or not was significant in all of them if the patient had neoplastic or reactive. So again, this is where we think the value is going to come into the medical record. And we are doing some of this here now with our clinician, even in our inbox. We have actually a project that I'm doing now with Dr. Al-Kai, Arif Al-Kai, where we are actually looking at the prioritization within Mayo Clinic of what notification to go to the consultant based on the AI and the and sensitivity. I'm going to go very quickly on the flow cytometry, and just to give you an example, I picked this publication from the University of Utah, where I used to work before I moved to Mayo Clinic a few years back, because I'm familiar a little bit with their system as well. So they used more than 3,400 cases, and they used what's called the UMAP, which is a feature extraction dimensionality reduction I talked about, using a single tube. It's a single B-cell tube, 10-color B-cell tube. And then they followed this by random forest classification for cases without gating on any specific population. So basically, they took FCS files and they applied in the algorithm, no gating, and were able to test it. And I'm just showing you a single case to give you an idea of how this works. This is a single case, and we look per marker, like on the CD10, that big population in red there. We know that these are neutrophils or granulocytes based on the fact of their expression of CD10 and where they are on the on the scatter.
You have 5 minutes to complete your talk.
Yeah, two more slides will be done. So 95%, I mean, with the B-cell malignancy, they were able to tell abnormalities or B-cell malignancy, 95% of accuracy based on this B-cell tube. If you look at the CLL with the area under the curve was even better. The algorithm didn't work very well on the T cells, which is expected because this is a B cell. What was unusual is that the AML, detection of AML, was actually worked very well, which is, I assume it's because of some of the side scatter and 45. What's interesting here is that when they adjusted the cutoff, the classifier cutoff into 100% sensitivity, they proposed that almost 11% of the cases, they could be with 100% confidence can be released without no human touches it. So essentially it comes from the machine, goes through the system, and with zero chance of error there. No technician, no human can. Obviously, this is theoretical. There's going to be a lot of validation on that, but this is going to be the future. Where we think the future is going to be in the healthcare. Essentially, we're going to have a tissue-based information, next-gen sequencing, molecular flow. All of these, they are going to go into, with the data science, they are going to go into diagnosis, prognosis, companion diagnostics, and obviously you can add the clinical outcome to this, and this is where the magic is going to happen. This is already have been done in other areas in pathology where it had been confirmed that the AI can predict outcome, disease progression, and mutation. The last slide for me here is where the value, everything we have to develop in the future have to improve patient safety, improve efficiency, improve service quality, and optimization of our work as a workforce, whether clinician, pathologists, technicians, technologists, healthcare staff. I just want to point out that one of the major limitations is going to be the industry. The industry will not invest in this area unless they see the return on investment. And actually, this goes back to us as healthcare providers and as practitioners. This is the summary. We talked about the promise in this area of AI and diagnostic workflow. We talked about some of the limitations, and we talked about the importance in the last slides of the practitioners being engaged in all stages of design. With this, I would leave you with the last quote: our imagination is the only limit to what we can hope to have in the future. And thank you again, and would like to take questions.
Thank you, Dr. Salam, for your presentation. We don't have a lot of time until our third speaker starts, so we will do the questions at the end, the question and answer period. So if you allow me, after thanking you for your wonderful presentation, I would also like to remind our audience we have reached now above 4,600 to continue to write down their questions under the question and answer function of the platform. So our third speaker this evening is Dr. Jennifer Brown. We'll just make sure that she is ready. Dr. Jennifer Brown is the director of the Chronic Lymphocytic Leukemia Center of the Division of Hematologic Malignancies at the Dana-Farber Cancer Institute. And she is a professor of medicine at the Harvard Medical School in Boston, Massachusetts. Her interests include the development of novel targeted therapeutics for chronic lymphocytic leukemia, as well as CLL genomics. Her talk this evening will be about updates on therapeutic innovations in CLL. We really would like to thank Dr. Brown for joining us this evening. Dr. Brown, the mic is yours.
Thank you very much for the invitation to speak. Can you hear me okay?
Loud and clear.
Great.
Just wait for your presentation to get uploaded.
Yeah, here it is. So after some discussion, we decided that I should speak about next generation BTK inhibitors in CLL, which I think we'll all be hearing a lot about over the next couple of years. Now, as you're all aware, we now have long-term follow-up of the first generation inhibitor, ibrutinib. This is from the RESONATE-2 frontline study in which ibrutinib was compared to chlorambucil in previously untreated CLL patients. And we now have 5-year follow-up with a progression-free survival of 70%. Yet 41% of patients needed to discontinue the drug, unfortunately, generally mostly due to adverse events. Progressions were relatively rare. And we know that many of those adverse events actually include cardiovascular toxicities. We see atrial fibrillation quite commonly. And in this analysis led by Javed Moslehi's group, in which we participated, we found enrichment for a variety of other vascular and cardiac events amongst patients treated with ibrutinib compared to patients treated with all other drugs recorded in Vigibase. So for example, CNS hemorrhage, heart failure, ventricular arrhythmias, which our group had also reported on from our own experience, conduction disorders, as well as ischemic stroke and hypertension were all enriched in ibrutinib-treated patients. And at ASH this year, we heard data again from the Ohio State group that their series of patients treated with ibrutinib had a very high incidence of new onset hypertension, 72%, and that this was associated with major cardiac events. We also heard from the MD Anderson that in their series of patients treated with ibrutinib, they see significant development of new hypertension in 71% of patients, as well as worsening heart failure, atrial fibrillation, brain hemorrhage, stroke, and CAD, as shown on the left. So it's becoming increasingly clear that ibrutinib carries a variety of side effects that can be troublesome over the long term, especially in our patients. Then once stopped, the median progression-free survival is about 2 years in this patient population from the ECOG study who'd been on ibrutinib for 15 months. So that's really not bad, 2 more years off therapy before progression. But nonetheless, once patients stop the drug, there's steady progression. So what about other BTK inhibitors in clinical development that hopefully might improve on this situation? So first, I'm going to talk about the 2 next-generation covalent inhibitors, acalabrutinib and zanubrutinib. And then we'll talk briefly about the non-covalent inhibitors that have been developed to combat resistance, specifically the C481S or other amino acid mutation associated with the resistance. So if we look at the kinome selectivity amongst the covalent BTKs as shown here, you can see that ibrutinib has a large number of larger red dots, which means it's not very specific for BTK. Zanubrutinib is quite a bit more specific on the left, but acalabrutinib is the most specific. Again, here, acalabrutinib, most specific, does not inhibit EGFR, does not inhibit SRC family kinases, does not inhibit TEC much, which is potentially significant for bleeding risk, and ITK at all, which is potentially significant for combinations with antibodies. Now, in the first phase 2 study with acalabrutinib in the relapsed refractory setting shown here, we saw progression-free survival similar to what we saw with ibrutinib. Specifically, patients with 17p and complex karyotype did have a shorter progression-free survival with median on the order of 2.5 years compared to other populations. The first frontline study in treatment-naive CLL compared 2 different doses, 100 milligrams BID, which as we know is now the selected dose, to 200 milligrams daily. And they look closely at BTK occupancy in this setting. And as you can see, the BID dosing maintained BTK occupancy much better than QD dosing, particularly at trough time points. The green is the BID dosing versus the orange of the QD. So this led to all patients switching to 100 milligrams BID. We now have 4-year follow-up of this study where the event-free survival is 90%. And this is particularly important because event-free survival includes drug discontinuation as an event. There was in fact only a 6% rate of discontinuation due to adverse events. Overall response rate 97%. And 86% of patients remain on therapy now with 4.5-year follow-up. The first registration trial was in the relapse setting. This was the ASCEND trial in which patients were randomized between acalabrutinib to investigator choice of adalimumab, rituximab, or BR. And the randomization was stratified by deletion 17p, ECOG, and number of prior therapies. In terms of patient characteristics, median age was in the late 60s. Patients had 1 to 2 prior therapies, so not as heavily pretreated as some of the earlier studies. And 17p was seen in about 15% of patients. Unmutated IGVH, however, was seen in about 80%. The study was quite significant for its primary outcome, which was progression-free survival. This is investigator-assessed progression-free survival in the final analysis, and you can see that the median for acalabrutinib has not nearly been reached versus 16.8 months for the combination of adalimumab, rituximab, or BR. And on the right, you can see that the 2 control arms, BR or adalimumab, rituximab, perform really quite similarly to each other in this setting. And interestingly, there was no difference in the acalabrutinib arms shown in purple amongst patients with 17p or without, or amongst patients with unmutated IGVH or without. This suggests that in the less heavily pretreated setting, deletion 17p or p53 mutation is not as adverse as it is in the more heavily pretreated patients. In terms of exposure, the median follow-up of the study at this time was about 22 months, and that was about the duration of exposure of patients on acalabrutinib. And part of the reason the idelalisib rituximab arm probably did not do so well is because of the 11.5-month exposure, with discontinuation of 56% for adverse events. In terms of the events of clinical interest for acalabrutinib, atrial fibrillation was 6% versus 3% in the control arm. Hypertension was 5% versus 4% in the control arm. No real difference in major hemorrhage or infections. So generally encouraging from a cardiovascular and other infections standpoint. The Elevate treatment naive study is the most recent registration trial. The study enrolled 535 patients with treatment naive CLL over the age of 65 or younger with comorbid conditions, and were stratified based on deletion 17p, ECOG status, or geographic region, and then randomized between acalabrutinib with obinutuzumab, acalabrutinib alone, or obinutuzumab chlorambucil. And the primary endpoint was progression-free survival between the acalabrutinib obinutuzumab and the chlorambucil obinutuzumab. There was no planned comparison between the acalabrutinib obinutuzumab and the acalabrutinib. And so progression-free survival, as reported most recently with a median follow-up of 28 months, was 93% in the acalabrutinib obinutuzumab arm, 87% in the acalabrutinib arm. And those are both significantly better than 47% in the obinutuzumab chlorambucil arm, as shown here. So perhaps most interesting in these data is the 6% improvement in PFS with the addition of obinutuzumab, which was unexpected based on experience from other studies. And as I said, it was an unplanned analysis, but nonetheless looks meaningful here. Now, if we look at the subgroups, there's generally uniform benefit with the addition of obinutuzumab to acala, except for the subgroup with IGVH mutation, the mutated IGVH group. This is interesting because the mutated IGVH group often has not benefited actually from the targeted therapy at all as compared to the chemoimmunotherapy in most of the studies. That's true of ibrutinib, for example. And what's suggested is perhaps that achieving a deeper remission for the mutated IGVH patients, similar to what we did with FCR, for example, and what we now do with venetoclax obinutuzumab, may result in particularly beneficial outcomes in those patients. Events of clinical interest in this study, atrial fibrillation over the 2.5 years is 3.4 to 3.9%. Remember, the obinutuzumab chlorambucil follow-up is only the 6 months on treatment, so it's much shorter. Arguably, the 3.4 to 3.9% is the background rate CLL amongst, of AFib amongst CLL patients based on what we've seen with Tate-Shanafelt's data. Hypertension, again, looks pretty comparable across the groups. There is more low-grade bleeding, but no increase in major bleeding. Some increase in infections, which we always expect. And second primary malignancies, again, it may be the follow-up of 2.5 years. Although we're seeing this in all our studies, ibrutinib, acalabrutinib, and venetoclax, that the rate of second primary malignancies is fairly high in these patients on targeted agents followed over several years. Personally, I think that this is mostly the disease, but it will be interesting to continue to follow patients over the longer term to see what happens with that rate. Now, honing in a little bit more on safety with acalabrutinib, there's a pooled analysis of 9 trials, which should be coming out in print soon. And you can see here that the overall rate of major hemorrhage is 3.6%, which is really pretty comparable to what we've seen with ibrutinib. AFib is 4.4%, which again may be background. There was 1 ventricular tachycardia amongst 1,000 patients, which again may be background. Hypertension was 7.6%. So not nearly as high as what we saw reported at ASH for ibrutinib, for example. And there's actually a study, prospective study, looking at the use of acalabrutinib in patients who've discontinued ibrutinib for adverse events. It's a relatively small study, which makes it a bit hard to interpret because relatively few patients are in each category. But you can see here, for example, that of patients who discontinued for atrial fibrillation, only 3 had recurrent atrial fibrillation on acalabrutinib. Similarly, only 1 out of 7 had recurrent arthralgia. Overall, 62% did not experience a recurrence of their adverse event on acalabrutinib. And with a median of 2-year follow-up, 80% remained on study. Only 12% had to discontinue due to adverse events, suggesting that the adverse event profile of acalabrutinib is in fact better than that of ibrutinib, even in the setting of patients who've already developed adverse events that could be related to the drug. A network meta-analysis of 27 studies was presented at ASH this past December and showed pretty convincingly lower rates of any grade or grade 3 hypertension or any grade or grade 3 atrial fibrillation with acalabrutinib compared to ibrutinib. Ultimately, of course, we're waiting for head-to-head data. That will be from the Elevate Relapse Refractory Study, which is a phase 3 study in previously treated high-risk CLL with deletion 11q and deletion 17 and/or deletion 17p. Patients were randomized between acalabrutinib and ibrutinib. And this has been announced to be positive by press release, but we have not yet seen the data. And it was a non-inferiority study from the standpoint of progression-free survival. Our group has explored acalabrutinib in the setting of combination trials, and we're particularly excited about a phase 2 study that we've been doing with acalabrutinib, venetoclax, and obinutuzumab for initial therapy of CLL, as illustrated here. Patients start acalabrutinib a month before obinutuzumab, and then on cycle 4, they start venetoclax after cytoreduction. The primary endpoints at cycle 16, after 12 cycles of venetoclax, patients who have undetectable MRD and complete remission can stop all therapy. If they still have detectable disease or partial remission, they can go to cycle 25, at which time they're reevaluated and can potentially stop. We reported updated data on this at ASH from 37 patients, 76% of whom achieved undetectable MRD in bone marrow at cycle 16, with 84% in peripheral blood. 11 patients so far have discontinued therapy for undetectable MRD. Median follow-up in those patients is only 4 months, so no patients have progressed, but the follow-up is still very short. But we're excited about this as a potentially time-limited regimen for reasonably fit CLL patients. It served also as the basis of this ongoing randomized phase 3 trial that I'm leading, comparing acalabrutinib venetoclax to acalabrutinib venetoclax obinutuzumab to chemoimmunotherapy with FCR or BR amongst treatment-naive subjects with active CLL without 17p deletion. This is a potentially registrational trial for those combination regimens. What do we know about resistance to acalabrutinib? Well, we do know that of 16 progressors reported by Ohio State University, 11 had C481S mutations and 2 had PLC gamma 2. So it's looking pretty similar to ibrutinib resistance, which is not surprising because the drug binds to the same cysteine, 481. Of 103 patients who were screened, 22 had mutations at a median of 32 months, and then it was about a year to relapse. So data that looks very similar to what they first reported with ibrutinib. Come back to this later. Now, what about zanubrutinib? So zanubrutinib is somewhat less selective for BTK than acalabrutinib. The main point where this may be important is in terms of TEC. It does inhibit TEC rather potently, just as potently as ibrutinib, and that could have effect on bleeding risk. Now, zanubrutinib dosing has been optimized very carefully to try and both attain complete BTK occupancy throughout the dosing interval, as well as to maintain PK levels of zanubrutinib in the blood, so that if there is BTK resynthesis, zanubrutinib is still around to inhibit BTK. And you can see that shown here in terms of even low doses, 40 milligrams or so of zanubrutinib, is similar to ibrutinib at 560. Acalabrutinib has an early peak, but then declines very rapidly with its very short half-life. And it's further illustrated here in terms of the plasma exposure, the PK, where in purple is the zanubrutinib at the selected dose of 160 BID, achieving about 10-fold free drug exposure compared to ibrutinib. And this correspondingly shows the very high BTK occupancy with zanubrutinib at the top, ibrutinib at the bottom, and on the right, you can see there's quite a bit of splay downward, which we're not seeing with these next generation inhibitors that were really optimized for occupancy. And zanubrutinib in particular looked at lymph nodes at screening and trough, and found that median trough occupancy was still 100% at the BID dosing schedule, which I do prefer because of this better data on occupancy compared to the QD dosing. The phase 1b trial included a significant cohort of CLL patients, which were updated at ASH last year, 123 patients, most of them relapsed refractory, median follow-up about 2.5 years. Median age of 67, 16% with 17p, so somewhat lower than some of the other relapse refractory studies at this point. And as with all the BTK inhibitors, what we see is over time, there's an increased accrual of complete remissions, still going up at month 36 as shown here. And this corresponds also with decreases in PR with lymphocytosis. Progression-free survival looks really good. 2 years is a relatively short time, of course, but 91% in the relapse refractory cohort at 2 years. Adverse events of interest, there has not been a clear cardiac signal in relatively limited patients. The main thing that's been noticeable is that there is more grade 3 neutropenia, although this is mostly an early event, first year, and in my experience is easily manageable with occasional growth factor. Infections were seen in this study as we see in all relapse refractory CLL studies. So the Sequoia study is an ongoing registration trial in the setting of treatment-naive CLL for patients over the age of 65 or otherwise unsuitable for FCR. And the only data that we've seen so far from this are cohort 2, which was a dedicated cohort of 17p patients with about 100 enrolled, all of whom were treated with continuous zanubrutinib. 109 patients, 14 are off study at the time of this presentation, which was at ASH last year. On study treatment, 95. And the overall response rate had continued to improve up to 94.5% with additional accrual of complete remissions. And the 18-month progression-free survival was 91%, which is really pretty good for deletion 17p patients. Adverse events of interest, again, in terms of grade 3, there were infections, as expected with 17p patients, and neutropenia. Now, we do actually have head-to-head data comparing zanubrutinib to ibrutinib, and this is in Waldenstrom's, the ASPEN study. And so here you can see in this head-to-head analysis that zanubrutinib significantly improved atrial fibrillation compared to ibrutinib, with trends toward improvement in hypertension, edema, and contusion. You'll note that neutropenia was higher, but pneumonia was actually still less in zanubrutinib-treated patients. So I think this certainly validates the better safety profile of zanubrutinib compared to ibrutinib. And we are, in fact, awaiting data from a similar study in CLL, in which zanubrutinib and ibrutinib were the randomized comparison. There's also been a triple drug regimen studied with zanubrutinib, and this comes out of the Memorial Sloan Kettering Cancer Center. This was a MRD-driven study continuously. So as patients achieved their first undetectable MRD, they just needed to have it confirmed and they could stop. And as a result, 89% of patients have now stopped after a median of 10 months, just 8 months of triplet. And the overall rate of undetectable MRD is 90%. You can see on the right that most patients are in blue, surveillance with undetectable MRD ongoing, although there has been one progressive disease. So it'll be interesting to see how this study with the shorter treatment period compares to some of the studies with longer treatment periods as we get longer follow-up.
Dr. Brown, you have 5 minutes to complete the talk.
Okay. Resistance to zanubrutinib has also been reported with BTK C481 as well as some Lu528 tryptophan mutations, which are a little unusual, but likely also affect binding. So what about the non-covalent inhibitors? So RTL531 is still in clinical development. It took a long time to get to its target dose, but at that dose, which is 65 milligrams daily, we did see significant partial remissions. And you can see a number of patients are ongoing on study. And I believe this is in ongoing phase 2 trials. LOXO305 is also a potent and selective non-covalent inhibitor, which was reported at ASH. You can see that the kinome selectivity is extremely specific for BTK. On the right, some data from my lab showing that LOXO305 completely inhibits phospho-BTK even at low concentrations in the setting of C481S within patient samples. These are samples from resistant patients. Ibrutinib has partial effect and acala none. So in the clinical data, 170 CLL patients have been treated, almost all exposed to BTK, about a third exposed to BCL2. About 2/3 came off for progressive disease. Interestingly, only a quarter were found to have C481 mutations. However, these are data that are still pending. They've only evaluated about half the patients yet. So it'll be interesting to see what emerges in that regard. The safety profile is really quite notable. If you look at the incidence of grade 3 and 4 adverse events here, this is across CLL and lymphoma, 323 relapse refractory patients. There are almost no grade 3-4 events, and there were no DLTs. Efficacy also looks very good. Overall response rate of 63% that raises up to 86% in patients on therapy for at least 10 months. There's no difference based on prior therapy, BTK or BCL2, or based on reason for prior BTKI discontinuation. Follow-up is still relatively short, as shown here, but it still looks very encouraging. This is, I think, a very exciting drug to keep your eye on for the future, given its tolerability and its efficacy in these heavily pretreated patients. In summary, acalabrutinib has demonstrated high efficacy and tolerability with a 90% event-free survival in a frontline cohort at 4 years. The randomized ASCEND and ELEVATE trials have led to the full approval of acalabrutinib by the FDA for CLL patients in any line of therapy, with or without obinutuzumab. Head-to-head data against ibrutinib are pending from ELEVATE relapse refractory, and we should hear them soon. Observational data suggests a significantly improved AE profile. Zanubrutinib has also demonstrated high efficacy and tolerability at shorter follow-up, with PFS greater than 90% in treatment-naive and relapse refractory cohorts at 24 months. Dedicated 17P cohort also looks good, and registration trials are ongoing in the frontline and relapse refractory settings, with the latter being a head-to-head trial versus ibrutinib. And of course, we've already seen data head-to-head in Waldenstrom's. And then the non-covalent BTKIs have significant activity in patients previously treated with covalent BTKIs, and I would keep your eye on them as we look to the next few years, where these will hopefully become available for our patients previously treated with BTK and venetoclax, and we'll also be seeing trials trying to move them frontline. These are my disclosures, and thank you very much for your attention.
Thank you very much, Dr. Brown. I would like to thank our speakers for their wonderful talks this evening. I would like now to invite them all to join me before the break to address questions from the audience. Dr. Salama and Dr. Al-Fayh. So some of the questions I had so far, I'll start by the first question to Dr. Brown. Do you believe that the addition of anti-CD20 has made acalabrutinib more effective than ibrutinib?
So, I do think the data with obinutuzumab together with acalabrutinib look quite encouraging. We do have data with obinutuzumab together with ibrutinib, which don't look as much better than ibrutinib data as this does compared to acala, but the patient population was different. The Illuminate patient population included a higher rate of P53 and 17P deleted patients, and there were no head-to-head comparisons to single agent. So it's hard to tell. But right now, I think that it does look encouraging that the acalabrutinib obinutuzumab combination may be potentially more potent than ibrutinib. Although unfortunately, we're not going to have frontline head-to-head data. We only have relapse data. And we need longer follow-up of that trial as well, which hopefully will be forthcoming later this year.
Okay. The next question is for Dr. Al-Freih. Do you think there is a potential for human errors, as there are huge information we will need to input into the artificial intelligence machine to analyze the data? So who should actually input this information, and whether this could lead to human errors?
So thank you, Mohammed, for the great question. So in deep learning, the extraction of the data should be automated, different than the machine learning. So definitely there might. So the quality of the output of the machine learning depends on the data itself. The quality and the size is very important. So the outcome depends on the input.
Okay, the next question is for Dr. Salama. So you have shown us amazing studies that made us think that, is it really time to go back to basics and rely on basics tests? So like peripheral blood film and smear, showing very high sensitivity in predicting specific diagnoses and differentiating one from other. Is this going to make us do less of the confirmatory advanced testing, or are we going to do them with confidence, or what?
Yeah, I think that's a great question. I think to answer this question, we have to go back to actually the previous question again, which is the value of the output or the input. 80% of the AI study, 80% of the effort is actually depending on the input or the annotation of the data. And it have to be very well data and the question that's answered. Now, I may be able to, we want to make sure we don't over interpret the results that have been done so far, because what I have shown is the promise of the AI. But I would not go in a clinical practice and say I can diagnose MDS from a peripheral blood study, because as I showed you also, the more you are going to add additional variables, then it becomes, the system becomes challenged. So we still have a long way to go. I think where we have reached in terms of gold standard of NGS or immunohistochemistry or double expressors or outcome, and at the end of the day, the clinical outcome is the gold standard, is what we refer to at the end of the day. But we still have a long way to go. I think there's going to be a lot of utility of it in the short run on a smaller scale operation, then eventually we're able to address some of that. But there is no question in my mind, in 5 to 10 years, we are not going to be practicing medicine the same way we are practicing it today. I'm just talking from a lab perspective. And obviously, what we will give you as a clinician is going to be different.
Okay, there is also another question for you, Dr. Salama. With now artificial intelligence, are we able to make it do more of not only a confirming one test, is more of a summation of multiple tests to lead into one diagnosis? So combining peripheral film, staining, flow, all together in one report, genomics?
Yeah, I think that is correct. So once we, as I said, we start doing this in one area, but then we'll have success here, success here, success here. So when we do flow cytometry, for example, we have we have to look at a slide and then decide which tubes will be ordered. So if I have an algorithm that can tell me the cell that now they can call the blast faster or give me more features that I didn't know before in the blast, that's predict P53 mutations, for example. And then eventually I would have the molecular, I can order that test. And then I have the flow data that actually confirms that this patient likely belongs to these. So now we're going to have an integrated report that's more standardized, that's more actually predicting the outcome. Chances are it's going to be predicting the response as well, because we are not going to be anymore trying. I mean, we may be able to say this patient is likely to respond to this therapy and not that therapy. So with the multimodality integration, as we have more success in this, this is really where we are going towards. What we still have a long way to go, but what I showed you again proves that this is achievable.
So next question is for Dr. Brown. Ibrutinib and the other the other drugs from this family has almost transformed the face of how CLL patient respond to therapy. Are we going to make these cardiac complications a potential showstoppers given the patient population? Have you seen any studies coming for like co-prescribing medications that could maybe minimize or alleviate these complications?
So I'm not aware of any studies that have pre-planned, for example, adding antihypertensives with ibrutinib up front, or something that might prevent, for example, the rare ventricular arrhythmias. But we've had several deaths in our practice from those, and so have most other people who use a lot of ibrutinib. Honestly, I think that the cardiac complications are significantly less with the other two drugs, acalabrutinib and zanubrutinib, and I think that's how we're going to get around it. There was a recent paper published in Circulation in December that identified the off-target for atrial fibrillation as CSK, which is inhibited by ibrutinib, but not by acalabrutinib. And in fact, in their mouse studies, they were able to show that acalabrutinib did not induce atrial fibrillation in the same way that ibrutinib did. And when you knock out BTK, you still got atrial fibrillation with ibrutinib because it was not dependent on BTK. It was really a very nicely done study. So I think the way hopefully we'll avoid this problem is that we'll move to the next generation drugs that don't have the same problem.
So given the huge effect of say BTK inhibitors or the new generations of CLL therapy on the disease, the question is for Dr. Brown. Do you actually think that the fact that we see the effective 17p deletion clone happening later is just because of the dynamic of the disease, because it's an indolent disease, or it's truly the effect of the selective pressure of the prior regimens on the other clones as the disease progresses?
Right. So I think that there's ongoing clonal selection even during ibrutinib therapy. We have a couple studies showing that there is, in fact, evolution during ibrutinib therapy. It doesn't select for 17p quite as strongly as chemoimmunotherapy, but it does to some extent select for 17p. And I think we'll see the same thing with venetoclax, that we may not get induction of new mutations like we did with chemoimmunotherapy, and the selection may be a little less strong, but that more or less as we move from therapy to therapy, we're still going to see selection of resistant clones. Also, we're trying to understand new resistant clones, right? These BTK mutations actually often confer aggressive behavior on the CLL, even if there's no 17p deletion. And we don't really know what the natural history of that will be, for example. Other than that, we do know that patients who've progressed on ibrutinib treated with venetoclax have a much shorter progression-free survival than those who haven't progressed previously on it. So I think our clonal evolution problems may just be a little bit different, but that they're still there. Well, unfortunately, it also probably will be later times than before, so we'll have longer treatment intervals before the clonal evolution problem.
So now with the this is again for Dr. Brown. Now with the MRD testing, we are seeing those studies are doing a lot of bone marrow testing on patients. Most of hematologists, they don't do a lot of bone marrow testing on their patients. Will that become a mandatory if patients are on BTK inhibitors throughout, or only to decide when the treatment is completed or cessated?
So MRD testing has actually very little value currently for patients on BTK inhibitors, because almost everyone on BTK inhibitors has only a partial remission, not even a complete remission. And undetectable MRD is vanishingly rare. So patients who are continuing on the BTK inhibitor, it doesn't really matter if they have some residual disease. Where we use the MRD testing is really more with time-limited regimens, so the venetoclax combinations, because there, the achievement of undetectable MRD when you stop the regimen is strongly associated with your subsequent duration of response and progression-free survival. In terms of the bone marrow versus peripheral blood question, I think most of us who do a lot of MRD studies and study it do think that it is a little bit more sensitive in bone marrow compared to blood. But you will notice that many of the randomized trials have specifically evaluated blood as the endpoint to predict outcome, so that you don't actually have to do a bone marrow. And the data increasingly suggests that whether or not you're in complete remission, which obviously requires a bone marrow to prove, is not as important as your MRD status. And the peripheral blood MRD status is almost as predictive or similarly predictive as the bone marrow. So people won't really probably have to do them.
Okay, so the next question is for Dr. Al-Freih. Do you think with ongoing evolution of artificial intelligence, we will be using such platform, hopefully with no technical barriers among countries, so we can reach for expert set of eyes or center on rare cases to help us reach diagnosis or help us analyze an algorithm to reach for a diagnosis for expert opinion overseas?
Thank you, Mohammed. So I agree with that. Actually, this is one of the advantages of AI and machine learning, is to augment the lack of, highly skilled professionals. However, there will be some shift in the highly skilled professionals. So, for example, now the current situation, we are looking for a physician who is expert in X disease. Probably in future, we will be looking for an AI expert in interpretation or looking to the data. So there will be definitely a still need for highly skilled professionals, but probably there will be some more shift toward those who have the skills for artificial intelligence and machine learning. Thank you.
Okay, and for Dr. Salama, my next question is, do you think with where artificial intelligence, or I will actually borrow your terminology, augmented intelligence is actually going to actually help us define or determine which patients are going to receive certain tests? Like, for example, just for simplicity, is bone marrow indicated in patient A or not? That's the first part. And then the second part, can a specific flow or algorithm, say your lab developed, can actually help, for example, my lab reach a certain diagnosis through a certain stain? So such systems or algorithms can be shared among centers?
Yes, I think the answer, the short answer to both of your questions is yes. And I honestly think it's going to be even more than just doing the peripheral smear. Going back to my point, AI is beyond imaging. So you, in a patient with anemia, you would be able to look at his anemia and the last, or progression of his anemia in the last 4 or 5 years, just from a CBC, punch in the numbers into an AI and can tell you with a very high level of confidence the 17 parameters from a CBC combination. This patient had 99% chance that become an MDS or something else. And then then you can decide on what additional testing to confirm. This is really what I likely expect things to be in the future. With regards to I think really AI is gonna help you in terms of intervention as a clinician. Now, this intervention could be another test or could be another therapeutic, depending on the testing, the question that's asked. We need to start with the low-hanging fruit. So if it's in your practice, you have a problem A, then this is where you start to look at the tools you have and maybe develop what would answer your practice that benefit from that, because the spectrum is so big. Now, going to the second question, what I just mentioned now, the reason why I mentioned this, because if you develop something in King Faisal or in King Saud or King Abdullah Hospital, I mean, whatever you have developed for your practice now, others in other country can use it. I don't have to, I may develop things are specific for my practice, but because of the connectivity, because telepathology, because of the AI algorithm itself, you can scan the slide across the globe. I can apply my algorithm on it, and then you can benefit from it. So you don't have to develop it itself. So I think this is where sharing of knowledge and sharing information, because now you don't have to share the data, but you share the tool that can be applied on a data and serve others. Hopefully this answered your question.
Thank you so much. Maybe we have a room for one final question for Dr. Brown. I don't know if do you use this in your practice using the value of beta-2 microglobulin to determine dosing for BTK inhibitors?
I don't use it to determine any dosing or even to decide on treatment, but I do monitor it as a sort of general evaluation of the patient's status in terms of their overall disease burden.
Okay, with that, we will conclude our question and answer period. Thank you very much for everyone, our audience, our speakers for augmenting this day of the conference. So at this point, it will be now the break where we can actually start and explore the virtual exhibition of the conference. It will start from now until 22:30, and then after that there will be another break, and then we will join back for the second part of the day. Thank you so much.
Thank you.
Thank you.
Thank you, Ahmed.
Yes, we can just leave.
Yeah, I think so.
Yep.
Nice to meet you. Great to connect.
Nice to meet you too.
Thank you so much. Nice to meet all of you.
Thank you.
Okay. Thank you, Dr. Muhammad Al-Maqadi, and for the speakers, Dr. Firas Al-Firih, Dr. Muhammad Salama, and Dr. Jennifer Brown for the excellent session we had. And now we start the last session of the day. Before we start, I would just want to remind everyone to please participate in the public chat and write your questions. We have, mashallah, close to 5,000 attendees. Our first talk today will be about artificial intelligence approaches in hematopoietic stem cell transplant. This will be delivered by Dr. Shahrukh Hashimi. Dr. Shahrukh Hashimi is currently the chairman of hematology and oncology at Sheikh Shakhbout Medical Center in Abu Dhabi, UAE. He's an international authority on graft versus host disease and BMT survivorship with greater than 100 publications in peer-reviewed journals. So without further ado, please, Dr. Shahrukh, you can start your talk.
Good morning, afternoon, evening. It's a great pleasure to present artificial intelligence in transplant. I'm at SSMC in Abu Dhabi, also supplementary consultant at Mayo Clinic in Rochester, Minnesota. I have no relevant conflicts of interest. Some other disclosures not related to the talk are given here on this slide. Today we're going to talk about AI in hematopoietic cell transplantation. And before that, I'm going to give a little bit background of the overall approach of AI in healthcare currently. As you can see in this slide, the AI, which I will refer to as machine learning, which is the #1 area of AI in healthcare, spans over 3 types of modalities. One is diagnostics, the other is prevention, and the last one is treatment. And all 3 areas is making significant impact, but the one that's the most commonly used currently clinically is the diagnostics. Some of the basic concepts of AI are depicted in this slide. A detailed discussion of each of them is beyond the scope of today's presentation, but suffice to say that the bottom line is the computer programming concepts, which is input and output. Also, knowledge engineering has increased significantly as far as AI is concerned, and this is a very, very advanced field within the AI. The automated planning of software is actually becoming more important now, especially with the unsupervised learning and the execution of tasks. And that is one of the areas where we can really utilize this in healthcare, especially in diagnostics planning. Next, we have computational learning, which is purely machine learning category. And think of that as an advanced statistical technique with the computing power. And that's the one that's implied in most of the papers published already in artificial intelligence in healthcare. And we're going to talk a little bit more about it in the next few slides. Then we have natural language processing, which is something that we've been using in radiology department for dictations and for others, for example, Dragon training and other softwares for a long period of time. And Siri in your iPhone and others are examples of natural language processing. Then we have another newer concept called social general intelligence in AI. I'm not going to go into detail because that's relatively new and it carries a lot of discussion, but that's a field that's upcoming and may have an implication in the bioethics as well. On the right hand, you will see that the most common utilization of AI in healthcare is on machine learning, especially a technique called neural networks. And you would quite frequently hear the terminology deep neural networks or convoluted neural networks, and that's actually this programming within the machine learning paradigm. And the other one that's very common I already described was NLP, which is natural language processing. Now let's shift gears towards what's happening currently in the world. This is a paper published 5 years ago in 2017, looking at the publications then in peer-reviewed journals of AI. And as you can see, cancer dominates the picture. Fast forward another 4 to 5 years, currently cancer and transplantation is quite dominant as far as progress in AI is concerned in healthcare. Cardiology, radiology, neurology, and other also fields in which it has made significant advances in practically every field. But when it comes to cancer, you're talking about radiology and pathology mainly. So there have been a lot of breakthroughs in AI. Before I go into
You are currently the
stem cell
only person in this
transplantation, I just
conference.
want to show you 3 papers which actually have changed the spectrum of how we think about AI in the world. One is skin cancer diagnosis, the other is retinal diseases, and the third is breast cancer. Now let me start with the melanoma image recognition. Stanford investigators compared thousands and thousands of images, actually more than 130,000 images of the skin tumors, and devised a program based on neural networks to actually recognize the images and then classify them according to the correct diagnoses. And for this, they had 21 board-certified dermatopathologists also looking into the same slides for classification of diseases. Obviously, this required a huge amount of work for annotations, but as you can see that the classification, the predicted labels by the CNN, which is convoluted neural networks, was much better than dermatologists. In fact, all dermatologists combined, indicating that the machine learning softwares can really read the biopsies, but also predict them accurately what they are, and classify that so that rapid action can be taken. And typically the way it works is actually you classify them, annotate them, and you have a decision tree given on the left, which is skin disease, benign, malignant, or it's actually within malignant, you can have different categories and then subcategories and subcategories. So pretty much typical decision tree classification based on machine learning software. So this really changed the thought the world thinks of machine learning softwares in diagnosis of cancers, especially skin cancers. And after this paper, this was in 2017, a lot more progress has been made already with respect to skin diagnoses. The next breakthrough that came in was predicting wet age-related macular degeneration using deep learning softwares. Now, this study is important because the AMD is one of the leading causes of blindness in the developed world. And if you diagnose one eye having AMD, there's a very high risk of that the other eye is going to also have AMD or progress to AMD and cause complete blindness. Now, we need a prediction system in order to intervene so that the other eye doesn't get blind. And that's what they did actually. These investigators looked into models of 3D OCTs. OCT is the optical coherence tomography, a quite common procedure, pretty standard of care in many ophthalmology clinics. And they mapped the macula, the retina, looked into the devising a program which was self-learning so that it can predict the AMD in a 6-month window going forward. And that's how they did it, in fact, that once the wet AMD was diagnosed in first eye, patient was referred for evaluation to ophthalmologist for the intravitreal injections. But actually the images formed the database, which is a big data, to model a program which can read and predict whether the other eye is going to be going ahead with AMD as well. What is the actual conversion risk? And this is a methodology given over time on the left-hand side for the fellow eye based on the OCT readings. And on the right hand, you can see actually that the months since progression was accurately predicted by this methodology. And this is important because this was actually achieving AUCs, which were 11% better than the ophthalmologists combined compared to the machine learning. And that thereby you can intervene early if you have this kind of software. Now, breast cancer screening is a big one. This is an important study published in Nature just last year. It looked into the images of mammogram screening from the United States and the UK, and it had a huge amount of NHS data. Now, the breast cancer screening is a little different in US versus UK because of the time interval of screening, for example, 2 to 3 years in UK versus 1 to 2 years in US. But if you had both the images data sets from US and UK, here it's given 25,000 from UK and 3,000 from US. Typically what happens in the UK, you have a double reading of the mammograms, and there's a follow-up as well, and the number of cancers diagnosed over time are much less because it's an infrequent event, 1.6% in UK versus 22%, about a fifth in the US because of the screening interval. But if you had a software that could read and predict the cancer risk over time, then you really would reduce the lead time bias, but also intervene early in some of the cancers. So, and when they actually made this kind of independent model based on deep neural networks, versus 6 radiologists not only was extremely accurate, but also was much faster and cost efficient. For the second reader of the mammogram, this study clearly showed in real world it can decrease the time taken for the second reader by 80%, which is a huge savings as far as time is concerned, and obviously cost is concerned as well. But let me show you something interesting, that the top 2 images are showing a small breast lesion which was missed by all 6 radiologists. And these are world-class radiologists who were only reading mammograms and extremely experienced ones. But the machine learning software picked it up. However, on the contrary, there's nothing perfect, because on the bottoms, you would see actually that this breast had a breast cancer which was read accurately by all 6 radiologists. And it was missed by the AI algorithm. But just telling you that none of the machine learning algorithms are perfect. The beauty of the AI algorithms is that anytime it identifies a mistake, or you actually do the input that this is you annotate a new finding, it can self-learn and become perfect and better and better. So that was just 3 of the many studies that have changed the spectrum how we think of AI into 2021. I'm going to shift gears towards stem cell transplantation. This is a very nice study done by our colleagues at NMDP in Minneapolis with collaborators, indicating that, when you call for a donor for a stem cell transplant for allograft, a lot of donors are unavailable. And how can you predict which ones are going to be unavailable? What are the causes of that? And they devised a very nice machine learning algorithm which can predict that these are the important causes based on which the donor may be unavailable. Now, this is important because currently we have approximately 14 million donors worldwide in all the registries, which pour into WMDA. This includes Anthony Nolan, NMDP, which is Beat the Match, DKMS, EKRD, and many others. So very nice algorithms for donor availability prediction, which is important for time factor for our patients who need an allograft. Now, Jocelyn Gallman, along with Madan Jagasia and many others at Vanderbilt and nationwide in the US, looked into the chronic GVHD consortium data and put in machine learning techniques which would actually classify different graft-versus-host disease clusters, because not all of them have the same overall survival. And this is what all of us see actually in BMT, that not one patient comes with only like chronic GVHD, which is uniform. They have more eye involvement or lung involvement or GI tract or skin musculoskeletal fascia. Now, when the actually machine learning algorithm looked in training and validating sets, it predicted 7 different categories with distinct outcome. And here in this graph, you're seeing the probability of being GVHD free over time. And the cluster 2, which is depicted in this graph in purple with joint and fascia involvement in sclerosis, had an extremely different outcome compared to the mouth and liver. Similarly, somebody having ocular and oral and vaginal GVHD may have a very different outcome. And this, I mean, begs you to think about treatment of these clusters may be different because of different outcomes. So maybe we're not treating them well. A very nice study by Catherine Lee. She's a Harvard Catalyst in Boston. She looked into graft versus host disease, acute grade 3 and 4 at 100 in about 10,000 patients from CIBMTR data. And clearly there were 3 distinct categories: low, medium, and high risk. And this is, I think, we think of treatment purposes based on this data, because the treatment paradigm of these group categories will be very different. And you may even preemptively treat, like we preemptively treat CMV. So this was based on machine learning algorithms, which could do thousands and thousands of computations within one regression, for example, analysis. I'm just giving an analogy that multiple variables can be put into one equation where cross-validation and cross-folding with deep neural network techniques, and you can come up with beautiful classification of different groups for a particular outcome. Ronnie Shuval published this paper in 2015, and this is 6 years old, looking at the eBMT data, thousands of patients data, and clearly the overall survival was very distinct based on 10 out of 20 variables that machine learning looked into and predicted survival. And that's how we should think about it. And maybe we should think about the survival based on the machine learning techniques when you see the patient first, rather than thinking, okay, look at the gender and CMV and the donor age and the HLA mismatch, the degree of HLA mismatch and the disease status, maybe all of them put together, and then you can get a very refined outlook for the survival. And this is another multiple myeloma predictions for relapse. And this beautiful study looked into many different factors and came up with some risks which were not considered to be the top risk for the PFS predictions. And you can see there the check one, low and high, was really a game changer as far as predictions concerned with respect to transplant. I mean, I don't even think of this when I'm looking at myeloma patients for autologous transplant, but clearly there's a lot of things we were missing with machine learning algorithms can connect many dots together. Basically, they're doing hundreds or thousands of regression analysis between different variables to predict, okay, these are the variables that are important for this particular patient as far as the outcome is concerned. So it's a truly personalized medicine. So let's just conclude by indicating that where are we going now? And in Saudi Arabia, Gulf countries, and in many other countries in the world, people look into the approvals for the drugs or softwares or devices in the US or EMA And then they start approving in their countries. And I've seen this because I live in this region, whether it be any drugs, in fact. So first question is US FDA approved? And the question is, when are we going to see the first AI technology approved by the US FDA for clinical use, not for research? And the answer I get sometimes is 5 years, 1 year, 2 years, this year. And sometimes it's the people always saying never. There's always people who have anti-AI mentality and want to indicate this is never going to happen. When in reality is this is a paper from September of 2020 indicating about 60 softwares that are already FDA approved and current clinical paradigm use because FDA has approved them, and 29 were on the FDA website that they have given in the table. As you can see, a lot of them are oncology and cardiology, neurology, but suffice to say that majority of them are looking at image recognition techniques, which may be TensorFlow or others, but basically they're looking at diagnostics, not for therapeutics at this moment. And to conclude, I mean, the radiology is by far the largest area in which the techniques have been very successful in predictions. And within radiology, cancer comes at the top. And we are living in a tech world. I mean, this is 2016, and 5 years down the road, this has changed dramatically in the favor of technology that, 20 years ago, things were different. Even in 2006, 15 years ago, ExxonMobil, GE, and many others like banks were BP, Shell, PetroChina were leading the world as far as companies, as far as value, the market share is concerned, not by revenues or assets. I'm talking about market share purely. And things change right away towards the companies because of a reason that they rule the world because of the way they have incorporated in our daily life, whether it's cell phones or whether it's other applications in a hospital. So we've got to think about AI, in fact, for everything. I mean, you think supply chain, finances, billing, coding. Yeah. So, but the limitations are many. Some of them I enlist here: technical faults, social, financial costs, and maintenance costs. Privacy issues are significant. Cybersecurity is a huge area of discussion. We're publishing papers on that. And then emotional deprivation, absence, limited novel idea generation, and insurance issues as well. So the take-home message is being that AI is being refined to help us and not to replace us. And it can help in time efficiency, accuracy in diagnostics, precision medicine, cost savings, and it's already shown to classify groups of patients with high and low risk of acute GVHD as far as BMT is concerned, and also clustering chronic GVHD. It can also help us in donor availability prediction. And already many FDA-approved softwares are currently in use for diagnostics. So it's just a matter of time before we actually get into this. So today, all of you have to decide where you want to be in this graph. This is from marketing, obviously, but this applies to every single field. Innovators, early adopters, early majority, late majority, or laggards, or actually as people who never want to change at all. I mean, and the people who are early adopters take the big pie. The innovators actually become billionaires, as some of you want to be, but really, if you don't be early adopters, it's been there for decades now, the field, but over 10 years, it has significantly increased. So if you don't enact it now, maybe we're either going to be late majority or laggards. So it's time for us to think about this seriously and put it in clinical practice to help us. And with that, I want to thank all of you and think about something that's going to help us, not replace us, in the framework of a proper bioethical cybersecurity network. With that, thank you very much for listening to me, and happy to entertain questions or discussion.
presentation today. That was a very exciting topic. I would just want to remind the audience that please, if you have any questions, you can write it in the public chat, and I will forward it to Dr. Shahrukh. So before we go to our next talk is Dr. Paulo. Okay. I just want to ask you a couple of questions, Dr. Shahrukh, if you don't mind. Do you see AI affecting the futures and the job markets for hematologists in the future and hematopathologists?
You are currently the only person in this conference.
Good morning, everybody. The title of my talk will be CAR T-cell therapy changing the treatment paradigm in relapsed refractory diffuse large B-cell lymphomas. My name is Paolo Corradini. I am professor of hematology at the University of Milano, and I am the head of the Division of Hematology and Bone Marrow Transplantation at the Cancer National Institute in Milano, Italy. These are my disclosures. And these are the topics that we will be touched by our presentation. The first one is the patient journey, then some patient-related issues, then the role of bridging therapy before CAR T cells, the outcome in clinical trials, and then the outcome in the real-life setting, the biomarkers we can have to predict disease response or toxicity, some product-related issues related to the manufacturing, and some toxicity issues, in particular, the late toxicity of CAR T cells. So if we look at the type of patients that we treat with the CAR T cells, our reference is the SCHOLAR-1 study. SCHOLAR-1 study included studies with refractory relapsed lymphomas, and you can see that the median overall survival was 6 months. And this is actually very good because it's part of a study, because in the real life, for these patients, the real overall survival is approximately 2 or 3 months. So patients with a really small prognosis. So what about the CAR T cell therapy? Is more than a one-step procedure, because we start from our patients, we perform a leukapheresis to collect the lymphocytes. The lymphocytes are sent to the manufacturing facilities of the company, where they are transduced with the viral vector. They are produced in vitro, obviously, they are expanded, and there are a lot of quality control before the CAR T cell comes back. The turnaround time is approximately between 3 and 4 weeks. It depends on the products. Now is shortening, but anyway, you have to plan a period between 3 and 4 weeks. And then the CAR T cell are infused to our patient after the lymphodepletion chemotherapy that usually is based on the use of fludarabine and cyclophosphamide. To cover this period of the manufacturing, maybe you require some bridging treatment for your patient to have a good disease control. So what do we have to consider when from a referring center a patient arrives to a CAR T cell center? First point is if CAR T cells are indicated in that patient, if the patient fulfills the reimbursement criteria, and if we can predict in some way disease outcome in terms of disease control and toxicity. One important point that has been highlighted in a paper by the Elapu group from the MD Anderson is that the age per se is not an exclusion criteria, although patients above 65 years of age, they have the same disease response, but they experience a greater amount of toxicity. So we should keep this in mind. In the patient selection, we have some factors that depend from the patient and other ones that are related to the lymphoma itself, so are disease related. If we look first at the lymphoma-related factors, we see that rapidly progressive disease is a problem, double hit or triple hit lymphomas are a problem. There is a poor efficacy beyond the fourth line, as it has been shown in the ZUMA trial. LDH levels higher than twice or more than twice the upper normal limit correlate with poor outcome and with greater toxicity. Bulky disease or extranodal disease again correlate with poor outcome. Some very simple, but I feel important biomarkers are the C-reactive protein level, the basal C-reactive protein, so the one before the infusion, and the peak ferritin level. Another point is that patients requiring bridging therapy usually they do worse. If we go to the patient-related issue, basically we look at comorbidities and lymphocyte fitness. So we should consider the age of the patient, the clinical history, the performance status, the history of infections, for example, or poor marrow function, the number of treatment received before, because it can influence the lymphocyte count and fitness of lymphocytes. And we need the lymphocytes with a good fitness to have effective CAR T cells. Then an important point is the patient compliance, the presence of caregivers, and so on. But a very, very important point, please exclude any type of infection when the patient is admitted for CAR T cell, because you have not to use CAR T cell if there is an infection ongoing. We do not want to have an inflammatory state in the patient before the infusion of CAR T cell. This is something very important and very practical in the daily clinic. What about the bridging therapy? We mentioned it before that bridging is frequently required because of rapidly growing disease, bulky disease, symptomatic patient for pain, or organ dysfunction because of lymphoma growing too rapidly. And another point can be also an expected delay in the CAR T cell production. We have now several regimens or drugs that we can use, but obviously it depends upon what the patient has received previously. Steroids alone are something that you can use. Gemcitabine with rituximab, lenalidomide, ibrutinib, although it is off-label, but works in MYD88 mutated large cell lymphoma, radiation, or in the setting of mediastinal lymphoma, the role of pembrolizumab or nivolumab, brentuximab is very, very important, is able to produce important cytoreduction, and we have a very good experience on it. But another advice, a practical advice, is never use bendamustine. Never use bendamustine before leukapheresis, because bendamustine damage the T lymphocytes that you need with a good fitness for the transduction. So never use bendamustine before leukapheresis. So what about the bridging therapy? This paper was a paper with the axicell molecule showing that the bridging therapy is very important. No bridging seems to have a trend for a better outcome compared to bridging. But this is not surprising, because patients requiring bridging are actually a sort of a bias. You start selecting out patients with a poor prognosis. So it's not surprising that if you have a lot of disease and you require bridging, you have a poor prognosis disease, and usually you do worse. So this is not surprising at all. What is important to me in this paper coming from the MD Anderson group is that if you see the blue curve and the red curve, no bridging and radiotherapy are doing the same in terms of progression-free and both also overall survival, compared to ST, that is systemic treatment, or CMT, that is combined modality treatment, that means chemo plus radiotherapy. So the chemo alone or the chemo plus radiotherapy are less good for our patient than radiotherapy alone. So again, an important message: when feasible, radiotherapy alone is a good option for bridging. If we go now to the Juliet clinical trial update at 40 months, so a long median follow-up, we can see some important things. I would say very important, because you can see this is the progression-free survival overall, okay, that is 36%, at 36 months, sorry, is 31%. But if we look at the patient in CR at 3 or 6 months, meaning that an early time point can predict the long-term outcome, the achievement of CR is absolutely essential for a long-term disease control, and the curves approximately 70% or above. So we have, let's say, really encouraging and important data. And in fact, among all responders, 60% were estimated to maintain that response at 24 and 36 months. We can extrapolate that people with such an aggressive disease in complete remission at 3 years is probably people that has been cured by the lymphoma. If we look now at some, let's say, real-world evidence data of T-Gen-Leclu-cell, the T cell, this work by the CIBMTR, led by Pasquini, was focused on both ALL and lymphomas, but now we will just look at the lymphoma patients that are 155 patients. And if we look in details, the comparison between the CIBMTR and the Juliet, the lower part of the panel, we see that in terms of overall survival, best response, duration of response at 6 or 12 months, PFS, overall survival, the results in the real life are very similar to the trial. And if we look in details at these survival curves, we can see that large B-cell lymphomas, here they have a progression-free survival of 48% at one year. And sorry, the duration of response is 48% at 1 year, and that the PFS is 26.4% at 1 year, and overall survival is 56%. So our conclusion are that the durability of the response when we compare Juliet trial, or let's say all the clinical trials done with the CAR T-cell, is pretty similar to what happens in the real life. If we look to the other product, so to the axi-cell, we see that they have, with again almost 40 months of median follow-up, a 47% of patients alive at 3 years, with the progression-free survival of 39% at 24 months. So results that are again very, very similar with the Juliet or the real-life data. And this again is an indication that data coming from different studies, they all show the durability of the response in a highly aggressive disease, highlighting the point that CAR T-cell may be a curative treatment. I would say a life-saving treatment. If we now look at some real data regarding axi-cell, this is the Loretta Nastupil study, again, a consortium in US led by the MD Anderson Cancer Center, and here we have some large studies. Here you see that they had the infusion of 275 patients. That is pretty interesting. It's much more than the other studies. And again, we can see some important things. The first one that I want to highlight is the role of ECOG, because an ECOG greater than 1 correlates with poor outcome in terms of progression-free and overall survival. So ECOG is very important, as well as is very important, I would say critical, the LDH level. The curves here split apart a lot, comparing normal LDH versus abnormally high. Here, I will show our personal experience at the Milano Cancer Center in Italy. We have infused now more than 60, 65 patients. I will present the first 55 standard of care, which means patients treated with commercially available cells. And again, you can see the first point that in the real life, you have a mixture of axi-cell and tisa-cell. Also because axi-cell has the indication of primary mediastinal, so you can use in two histologies. All patients were heavily pretreated, and a large part of them had elevated LDH. Of course, this is not a formal comparison because it's not a randomized trial. Histologies were different, and the risk factor of the patients were not the same. But it is just to give you, let's say, a flavor of what happens in a center that start the treatment with CAR T-cell and use all what is available commercially. If we look at the progression-free survival is 40% at 1 year, so exactly the same of the real life and Juliet trial that you have seen before. If we look at the overall survival is 77%, and again is very similar. But if you look, keeping in mind that this is not a formal comparison, but is just a very preliminary report, just to look at the activity of the two products, we do not see any difference when we look at the patient infused with axi-cell or tisa-cell for what regards progression-free survival or even overall survival. And this again reinforces the notion that this type of treatment is effective and probably curative for a large fraction of patients. This is again an important study that we presented this year at the EHA EBMT CAR T-cell meeting in Europe that unfortunately has been online due to the COVID pandemic that is changing so much our lives, and was done within the patient of the Juliet trial with a lot of co-investigators, and we did this with Ulrich Jäger and Schuster and a lot of other friends, Michael Bishop, Gilles Sal, and so on. So we tried to look for simple biomarkers to predict the outcome of the patient receiving tisa-cell. So if you look to an important gene that is MYC, and you look to the expression of MYC above or below 40% by a simple immunohistochemistry, you see that the duration of response, the green line, PFS and the OS, is absolutely different, a small difference for the OS. The number, unfortunately, are small, but it gives you a little bit the idea that probably the MYC expression correlates, as it happens with chemotherapy, with a more aggressive disease, and also for the CAR T-cell can be a problem. If we look to the infiltrating lymphocytes, the CD3 infiltrating lymphocytes, so within the lymphoma, we look at the presence more or less 3% of CD3, normal CD3, not CAR T-cell. We see that if you have a tissue infiltrated by lymphocyte, your progression-free survival is better. It means that the immune system is able in those patients to penetrate the tumor, and probably also the CAR T-cell will follow the same way, penetrating the tumor. Another marker of the immunity, but is an immune suppressive molecule, the LAG3 expression on CD3 cells above or below 20% again, has a dramatical influence on the prognosis. And again, this is something very simple. You can study by immunohistochemistry in your pathology department on the paraffin-embedded tissue. So it's something that is feasible for everybody. And you looked at the duration of response, the PFS, and the overall survival are really dramatically different. So this is something very important, because in the future, we hope that when we see this situation before CAR T-cell, we can somehow manipulate the protocol of CAR T-cell to overcome the poor prognosis of the LAG3 expression. So the conclusion has been already done. So MYC, CD3 LAG3 cells are important, as well as the infiltration of CD3 cells are very important, but also simple biomarkers that can be applied in the standard clinical practice. The results are preliminary, but anyway, give some information to the clinician. Then we look to another point, which is the last point of this, that is the product. So the production of CAR T-cell for T-cell cell can influence the outcome. This was a paper presented by Veronica Bacanova at the ASH 2019. And obviously, we analyzed the Juliet trial patients, and we looked at the cell viability and the influence on the PFS at 3 months, and there was no influence. We looked at the cell viability versus CR. Oh, I'm sorry. Okay. Versus CR or neurotoxicity, and there was no difference. Then we looked at transduction efficiency. So the efficiency of transduction has a wide range between 5 and 63%. The average is 28. We wanted to see if they had an influence, the efficiency of transduction, on CRS and neurotoxicity, as well as an influence on progression-free survival or disease response at 3 months. And this was not the case. I mean, I'm perfectly aware that the number that I'm presenting on the influence of cell product are very small and somehow can be considered also strange. But to me, what comes up is that it's not only a problem of cell product, it's also a problem of the host receiving the cell product. So it's not something that can be played only by a more efficient transduction or a more viable T cells to be given to the patient. Last point that I want to touch upon is the problem of the toxicity. This paper coming from the Memorial Sloan Kettering in New York showed that the people receiving CAR T-cell has a high burden of toxicity. As you can see, toxicity are very manageable. Now, very, very few patients go to the ICU. Most of the toxicity were hematologic before. Obviously, there is the lymphodepletion role in that, or metabolic, or they can have infections. If we look at the data on 60 patients of Memorial Sloan Kettering by the group led by Miguel Perales, you see that in terms of event-free survival or overall survival at 1 year, the results are the same that we have seen at the Istituto Nazionale Tumori in Italy. So also the Memorial Sloan Kettering, they were using axi-cell and T-cell as we did. And results are the same. So again, this reinforced the notion that this type of results coming from the real world data are solid now, that you cure a fraction of patients that have no other options, but you can cure them with the CAR T-cell treatment. If we look at the very last point, that is a very recent paper, but is very important to me, is a paper dealing with the problem of cytopenia, but not only cytopenia, which is approximately 30% within the first 3 months for all patients, so correlates with infections, but also to the B cell and T cell reconstitution. Here, I want to highlight the point that 50% of patients at 18 months after CAR T-cell, they have CD4 T cells below 200 per microliter. So I would say a situation important in terms of risk of opportunistic infection. So this paper highlights the point that you require a prophylaxis for opportunistic infection in CAR T-cell patients that is exactly similar to the one you use in allogeneic transplantation. So our final conclusion are that CAR T-cell can control an active disease in approximately 35–40% of patients at 3 years. Patient selection and bridge chemotherapy are critical steps for a good outcome and for a good control of toxicity. Obviously, the emerging toxicity is that late cytopenia correlates with infections, and the problems of immune reconstitution also correlates with infection. And I would like also to highlight this very pragmatic point that a very channel of good communication has to be established with the referral center and the CAR T-cell center, because if there are late toxicity, the referral center should be able to go in touch immediately with the CAR T-cell center. And this is the acknowledgement to all the people in our division that are working on the CAR T-cell program. And I thank you for your attention. I am ready to take your question. Thank you.
Thank you, Professor.
Ayman, I think you could stop the recording now.
Thank you, Dr. Paolo Corradini, for this excellent presentation. I will remind the audience to post questions in the public chat if you have any questions. I will start by asking a couple of questions. For Dr. Corradini, in terms of, since CAR T-cell usually do better in tumors that are infiltrated by normal T-cells, is there any role of adding a checkpoint inhibitor to CAR T-cells?
As you know, there are trials ongoing just using pembrolizumab or nivolumab before collecting lymphocytes, before transduction, and also after the infusion of CAR T-cell. We do not have the clinical data, so the results of the trials, but what you said is absolutely right. People is trying to, let's say, improve the response of CAR T-cells, adding checkpoint inhibitors.
Okay, thank you. Another question, does the presence of cytokine release syndrome correlate with the prognosis and the response to treatment or not?
This is something that was a matter of debate, so that the people experiencing CRS usually responded and people not showing CRS not. This is not completely true, because we do have people having a nice complete response even with a grade 1 CRS or no CRS. So I would say that the problem is if the patient expand the CAR T cell in the blood in the first 2 weeks more than with the development of CRS.
Okay. Okay. I see another questions here from the audience. When you say there is a survival after CAR T cells, does that mean the patient can return back to normal life, or the patient still suffers the complications of the therapy? How many?
Let's say that you do not have, like in allogeneic transplantation, chronic GVHD or such type of late effects, complications. So if patients go back into complete remission, for example, in our experience, it happens when we put the patient on a bispecific antibody trial, the quality of life is okay. There are no late effects.
Okay.
It's true that we do not know how long this remission after CAR T cell failure will last, but we had also 3 patients in which we went back into remission after CAR T cell failure, and then we consolidated the result with allogeneic transplantation.
Okay. Do you see late relapses with after CAR T cells?
Unfortunately, in our experience of 60 patients, we had 3 late relapse, and we consider a late relapse a relapse between 6 months and 1 year. We have actually had 2 patients with the primary mediastinal lymphoma relapsing at 1 year, and not diffuse large B-cell lymphoma so far, I would say.
Okay. And would you offer another drug, another CAR T cell for these patients or not? For late
this is not allowed by the Italian healthcare to do 2 CAR T cell, but I have also to say that if people expanded the CAR T cell before, had a response, and then relapsed, there is the experience of the MD Anderson, Satvan Elapu, who tried to give a CAR T cell again, but they had a response only in patients already having a CR before, and it lasted not a long time, just a few months, and then the disease was back.
And what do you typically do for patients who relapse after CAR T cells? Do you take them for an allogeneic bone marrow transplant?
Allogeneic can be performed only if they are in complete remission, because if not, you do not have a let's say, long-term remission if you transplant people with refractory disease. We try to put them in some clinical trials, and most of our patients received or bispecific antibodies or ibrutinib if they were MYD88 mutated cases.
Thank you. Thank you. This is very helpful. Let me look here through the comment and see if there is anyone wants to. If anyone wants to ask, please write it in the public chat. Is there any specific performance status that usually you require before taking the patients for a CAR T cells?
Yes, in Europe there are some countries that allow also an ECOG2, for example, France and Germany, while other countries like Italy, UK, and Spain, they require, like in the clinical trials, an ECOG of 0.1. And the prognosis of ECOG2, at least in the real life data, it's not very good.
Okay, and they need to have a normal ejection normal cardiac functions, normal kidney functions.
Yes, this is a requirement for reimbursement in Italy. There are trials, as you know, with the lysocell, for example, or other molecules that they focus on patients having comorbidities to demonstrate that is also feasible in patients with comorbidities. I mean, the data are very preliminary, and my suggestion is to give Carticel with patients with normal or not heavily impaired organ functions.
Okay. Where do you see the value or the use for an allogeneic CAR T cells?
I have to say that in the lymphoma setting, allogeneic transplantation is very infrequent after Carticel, because you are in the situation that 35–40% of people achieve a stable remission. The other one experience a rapidly progressive disease. And so it's very difficult to have a rescue with some experimental drugs and then bring the patient to allogeneic transplantation. We could transplant only 3 patients out of more than 25 having a relapse.
Okay, okay. And do you, given the low incidence of cytokine release syndrome with NK cell CAR, do you see them as a potential replacement for CAR T cells in the future?
That's a difficult question. I'm not sure that one cell therapy will replace another one. I think that probably we will have more cell therapies as therapeutic options for our patients, and we will pick up the more appropriate for that clinical condition. So I don't see the NK as a complete substitute of the T lymphocyte for the moment.
Okay, okay. Thank you. Thank you, Dr. Corradini, for your presentations and for answering the questions. Thank you, Dr. Sharouk Hashimi, for your for answering all the questions, and thank for the audience for attending these lectures. I would remind you, please visit the virtual meeting, and there is many abstract that worth reviewing. And thank you for attending.
Thank you for invitation.
Thanks, everyone.
Bye-bye.
Bye.
Thank you, Professor.
So what we do now? You give back the control to my computer, or there is something that I need to do, or I can just leave the meeting and that's it? Oh.